This conference will now be recorded.
Okay, so today we're talking about the benign disease of the rectum. Last time we had talked about the surgical anatomy and the uh, rectal prolapse, which is again a benign problem with the rectum. We talk about the other benign problems today, right? So let's start with proctitis first, and fairly common problem. And the presentations all logically. Its presentation is in two form. One is acute or chronic, and symptoms are tenesmus, which we all know is defined as hematochezia with pus discharge, minimal fecal content, and a strong urge to defecate. It could be diarrhea, and specific symptoms could be there, could not be there. Even if they're usually minimal. And the usual investigation form of sigmoidoscopy and colonoscopy with a biopsy, and of course stool cultures. The types, basically one which is the most common probably is a non-specific type, which is a mild form of ulcerative colitis, and only limited to the distal rectum, about 5 to 15 centimeters from the anal verge. And no ulcers are seen in this minimal, the mild form of ulcerative colitis, in contrast to the full-blown ulcerative colitis where you find those ulcers, right? Second, it could be part of the IBD, a full-blown ulcerative colitis, or a Crohn's disease. Crohn's is more common in the rectum and associated with the anal disease also. You'll find perineal disease of Crohn's. You can have multiple fistula in anal. And the typical cobblestone mucosa pattern could be seen on a either sigmoidoscopy or a colonoscopy examination. We'd like to see for more proximal part being involved by Crohn's disease. Or it could be secondary to emic dysentery or emic granuloma. Both the conditions could be there. In dysentery, you'll find those typical emic ulcers, which we have known as inverted flower-shaped ulcers, bottleneck with undermined edges, and you find a yellow necrotic floor and pus and blood. Emic granuloma, on the other hand, you'll find a lump, and this is a ulcerative growth which is friable. The lump is palpable abdominally, and it is usually has to be differentiated from malignancy. And the diagnosis is pretty simple. Just take scrapings and send it for HPE, and find there is no evidence of any malignancy out there. Or it could be bacillary dysentery. We'll find multiple shallow ulcers. Similarly, you can also find two forms of tubercular manifestation, either for tubercular ulcer or in the form of tubercular granuloma. Both the conditions, you'll have some associated either past history or present history of pulmonary tuberculosis in these patients, right? The tuberculosis are again the typical undermined edges ulcer, right? And the growth is similar to emic granuloma. Here also you'll be able to palpate this growth per abdominally, and it has to be differentiated from malignancy by a biopsy. Even less common are or I would say even rare now, especially gonococcal, which you hardly find these days. So in the female, it could manifest as a vulval infection from the vulva or from the rectal coitus, or it could be in males after a coitus. Clostridial infection in the form of pseudomembranous colitis, which is gives maximal systemic symptoms and early septic shock, and usually seen in those patients who are on antibiotic therapy. So it's usually seen as a super infection. Or lymphogranulovenereum, you will find it as associated with AIDS, where you will find associated CMV, herpes simplex, and parasites will also be seen in these patients. Or a strawberry lesion, named because you got a typical macroscopic, you'll find a lump, a very small lump protruding, and on that you find those multiple oozing sites, just like overripe strawberry. So that's why it's known as strawberry lesion, and usually appears as ulceration at rectosigmoid site or a very minor raised growth, and usually caused by a spirochetal infection, right? Or it could be bacillus fusiformis. Bilharziasis infection, schistosomiasis, by Schistosomia mansoni, or a repeated herbal enemas can give rise to a similar proctitis, or it could be following a radiation. And radiation usually for a carcinoma of cervix, or a prostate in the males, or a rectal radiation. And it will present again as two forms: one the acute phase as pain, diarrhea, bleeding, or in the later months, the chronic form when post-radiational fibrosis sets in. So these patients can even present with stenosis. The treatment is pretty simple. Either treat the cause, and if you don't find a specific cause, then in these patients you use 5-aminosalicylic acid as enemas or suppositories. You can use oral steroids or local steroids, and most of these patients they respond. Coming to the other benign lesions, and the first one we'll talk about the rectal prolapse, the benign lymphomas, endometrioma, the hemangioma, JST, and neuroendocrine tumors. First, let's talk about the benign lymphoma because they are pretty uncommon, and they also referred to as pseudolymphoma or as a benign lymphoid aplasia, and both the names are to a certain extent self-explanatory. The pseudo basically tells you that it's not a true lymphoma, or a benign lymphoid aplasia tells you is basically a hypoplastic condition, not a tumorous condition, and it is benign, right? So it's a rare tumor of the lymphocytes, indolent, non-invasive, and you don't find trauma or injuries and inflammation or infection. Any one of these causes could be the cause for development of a pseudolymphoma. The treatment is pretty simple. Either you carry out a chemotherapy for these patients, easily surgical excision can be carried out, right? To the second one, and that is endometriosis. Yes, we're basically talking about endometrial lining. Show the mic, please. Again, age is the usual presentation age. That could be one. Number two, rectal invasion from the rectovaginal septum. That would be the second manifestation. Third manifestation. Kindly, kindly close the mic. I'm waiting for the mic. Somebody. Thank you. So the treatment is either hormonal, you can use hormonal therapy, or if you want to carry out a surgical therapy, then it has to be a basic PAH with bilateral salpingo-oophorectomy, and then that has to be combined with either bowel resection or a laparoscopic rectal resection or an isolated diathermic cauterization of the rectal lesion, or it could be a local excision. So the basic PAH with bilateral SO has to be carried out, and in conjunction with that, you get some form of therapy for the rectal lesion. Hemangioma is another condition which may be confused with malignancy for the simple reason that you've got a lot of bleeding. Hematochezia is the usual presentation, and then you have to look for other causes of hematochezia. And chief among them, number one could be the malignancy, number two, inflammatory bowel diseases, and diverticulosis, the three important causes, common cause for hematochezia. And don't forget vascular ectasia, especially in the old age female, old age person, whether it's male or female, doesn't make a difference. So vascular ectasia is perhaps one of the very common causes of hematochezia in a person aged more than 60 years of age, whether it's a male or a female. The diagnosis, either endoscopic study, that means a colonoscopy or a sigmoidoscopy. But remember, MRA is an important part of the diagnosis because in a colonoscopy, you don't find anything. In fact, during the intervening period between two episodes, there's hardly any bleeding site to be seen. You can't find a bleeding site, and that is what confounds the problem. And that is when you have to take a MRA, that's an angiography, magnetic resonance angiography, which perhaps may show you the sign of bleeding. And short of that, if no, then that creates a problem, right? That is vascular ectasia. So in an endoscopic study, you'll see that hemangioma. Hemangioma is usually seen in endoscopic study, but that's for differentiation from vascular ectasia. The treatment again is either embolization or excision. Excision can easily be done with a laser or a radiofrequency ablation, right? Coming to the rectal gastrointestinal soft tissue tumors. Now that is one of the problematic areas. Fortunately, it's a rare malignancy, as 1 to 2% only of GI malignancies, but it's a very highly malignant neoplasm. And among the GISTs, the most common one is leiomyosarcoma. And these are mesenchymal tumors from the smooth muscle cell. That's the most common type of GIST. And these are basically arising from the muscularis propria and muscularis mucosa layers of bowel wall. And there the receptors CD17, 34, and 44 are negative. That's what differentiates from a GIST. And spread is primarily to the lung. That is just a few words about the leiomyosarcoma, because that has to be differentiated from the other GISTs, right? Now, they lack the characteristics of smooth muscle tumor as is seen in leiomyosarcoma. They usually occur in the 5th to 6th decades of life, and they are uncommon GI malignancy, but on top of that, they are uncommon in the rectum, right? So they will be presenting either as an interluminal or extraluminal growth towards the adjacent structures, and you'll find the cell of origin as the Cajal cells. These are basically the interstitial cells, mesenchymal cells. They're located within the muscle, and they're responsible for the peristaltic activity, right? The markers are important. How do you identify a GIST? And for identification of GIST, you basically have to have the KIT marker. They're all KIT positive. 95% of them are KIT positive. That basically tells you that CD117 would be positive in all these patients. That's a KIT positivity. Then, in addition to that, you'll find CD34 in 70% of these patients. So 95% CD17 and 70% of GIST will show CD34, and that's also an indicator of a malignant phenotype. So the more the CD34, the more the chances that this patient probably may be having a malignant GIST. CD44 is variably expressed. You may or may not find this, and it correlates with the better prognosis. So CD34 with a poor prognosis because more malignant, CD44 less found, but probably an indicator of a better prognosis. Another marker that we usually find in these is a receptor, that's the platelet-derived growth factor receptor alpha, but it's only found in 10% of GIST. So these are the markers which will identify the GIST tumor for you. So see, remember CD117, CD34, CD44, and the PDGFRA, platelet-derived growth factor receptor alpha. But one thing I would like to point out here, these are not the only markers, but these are the important markers, right? The malignant variety is indicated by number one, a high mitotic index. I mean, you have a mitotic index of cells dividing at the rate of more than 5 per 50 HPF, that is known as a malignant variety of GIST. Less than 5 is probably a non-malignant variety. And the other histological parameters add to the diagnosis, namely the cellularity types, the atypical cells or the atypical nucleus, and necrosis. They also have to be taken into consideration before you classify rectal GIST as being malignant. The symptoms, as in other GIST, is usually asymptomatic or with non-specific symptomatology. And usually 75% of them would be diagnosed when you're doing either a radiological study or endoscopic or a surgical procedure for some other reason, and you identify accidentally that this patient also has a GIST, right? So it's an accidental or incidental diagnosis. Later on, when they grow large enough, then they have presenting with later abdominal pain, or if they are intraluminal, then necrosis leads to often a massive amount of GI bleed. That's because of the necrosis. So these could be the presentation of a GIST, whether it's intraluminal or extraluminal, depending upon that. And spread is always primarily to the liver and peritoneum. Lymph node spread is found in less than 10% of cases. Primarily, it's a hematogenous and a local spread if it is extraluminal. The diagnosis, we have the routine diagnostic criteria, or rather the aid of these diagnostic radiography, diagnostic ultrasonography, computed MRI, and positron, which is a common usage in almost diagnostic parameters in almost all the disease. Now, the treatment is surgery. It has to be a treatment of choice, and it is now also being tackled laparoscopically. So if you're doing it laparoscopically, that is the preferred method. So it has to be preferably laparoscopically for both primary and secondaries of a GIST, right? Imatinib is basically given as an oral, and it is now a very important drug in the treatment of GIST. Why? Because number one, it forms the standard choice for adjuvant therapy. Once you've done surgery, you have to give this patient imatinib. Locally advanced inoperable, the treatment of choice, and metastatic GIST, again the treatment choice, right? Coming to the other, that's the neuroendocrine tumors, and they are slightly important. Why? Because one of the neuroendocrine tumors identified in the rectum is a carcinoid, right? So 19% of all GI nets, that is basically the rectal nets, right? Histologically can be classified as based on two things. Number one, the microtic index, and number two is the Ki-67 marker expression. If they're there, then it is probably neuroendocrine tumor. Now, base classification, the three types. Number one, grade 1, grade 2, and grade 3. The majority of them, fortunately, are grade 1, and these are also known as carcinoid tumors. Well differentiated, good prognosis, clinically indolent, that means very slow growing, 1 to 2 centimeters in size, solitary, and they appear as elevated, smooth, rounded yellow gray or tan nodules when you're doing a colonoscopic examination, and they're usually benign as appendicular, and in contrast to more malignant colonic and small bowel carcinoid. What this basically means is that if you have a carcinoid of the rectum or a carcinoid of the appendix, you're fortunate enough, you've got a choice between carcinoid, you would select a appendicular or a rectal carcinoid. Why? Because they are relatively benign, in contrast to which are more malignant, and that is that these are the colonic and the small bowel carcinoid. They're much more malignant. Okay, grade 2 is again somewhere in between grade 1 and grade 3, but grade 3, which forms less than 0.5% of all colorectal cancers, CRC is a colorectal cancer. They are poorly differentiated, very aggressive, and they have got two cell types, small and large cell type, and they are functioning syndromes, right? You can have the CVAs, the skin, the GID, pulmonary symptoms there, and early metastasis to the liver and then to the lungs and bone would be usually found in these patients, right? The treatment, primary including lymph nodes, is endoscopically or transanally excision. If they're more than 2 centimeters in size, then a formal oncological resection has to be done, and the associated lymphadenopathy has to be done, right? If you got meds and you find that this patient is not amenable to surgery, then you have to have a combination of any of these drugs, and the whole list of drugs has been enumerated. Of course, some of them, not all, you can note them down. But alternatively, you can use octreotide, which reduces the symptoms in these patients. You're not really doing anything for the lump. You just reduce the symptoms because of the net that you have. And you have basically targeted somatostatin. That basically means you can directly feed it into the hepatic artery. Or you can do hepatic artery ligation, as is true for any other liver meds, right? Solitary rectal ulcer syndrome is again an important condition because it was identified pretty late. Initially, we never used to talk about this syndrome because we didn't know about this syndrome, right? So this is basically an ulcer found in the anterior wall, 8 centimeters from the verge. Pretty specific, pretty specific. Why? Because this is the area where the maximum amount of strain or pressure is exerted when the person is straining. And that's why this is usually found in those patients who are pretty constipated. Okay, so the cause is a combination of increased intrarectal pressure. So this patient exerting pressure, and that is there in constipation. Plus, with the pressure, remember we talked about the interception of the anterectal wall. That is exactly what's happening in these patients. So there's an ulcer and interception of the anterectal wall. And the patient, because the ulcer presents with bleeding and presenting with discharge. The treatment, the problem is it's pretty resistant to treatment. It doesn't heal. It doesn't heal. Take care of the constipation, probably there may be some kind of a relief, but usually the ulcers rarely heal. Uncommonly, they may spontaneously heal, and when they heal, they leave behind a polypoidal lesion. Difficult to treat, as I said earlier, resistant treatment. So then what can we do? In these patients, either you carry out a star therapy, which we talked about when we were talking about the rectal prolapse. And here what we'll do, you'll remove the whole area, which is housing the ulcer. So if you're removing the whole area, the ulcer goes along with it. Or you can do abdominal rectopexy, which probably does helps by reducing the constipative pressure on this area. Constipative pressure basically means the increased intrarectal pressure, right? So doing an abdominal rectopexy, or you can do rectal excision. This will be a very formidable operation when you consider this small ulcer, right? Coming to the very important topic, and that's the rectal polyps. Now, what about the rectal polyps? Let's look at the figures that are available. Age 60, 1/3 or more people will be having at least one polyp. At least one polyp. So these are some of the figures which are available for the polyp. The frequency, 70% are adenomatous polyps. That is again a very important figure. That's why it's been given in bold letter. And why? Because adenomatous polyps are the pre-malignant polyps, or those polyps which have got a tendency to change into malignant. And 70% is quite a high percentage. 20% are hyperplastic polyps. They again have got a very low potential for malignancy. And 10%, remaining 10% are the other kinds, and these are basically the serrated adenomas, the sessile serrated adenomas, and mixed mucosal polyps, right? Now, the sex usually found more in the males. Etiology is probably unknown, but you do have some risk factors which are or which could be identified in these patients who have got an increased tendency for polyp formation. Like, for example, the lifestyle figures like diet, high in red meat and fat, and obesity, lack of exercise, cigarette smoking, alcohol consumption. These are some of the factors which probably stimulate the formation of polyp. And these, remember, are the same factors which are factors which stimulate the formation of a CRC, or they are factors which are important in the genesis of CRC, that's colorectal cancer, right? So we'll be again encountering these factors when we talk about the rectal carcinoma. So genetic predisposition may be there. It's usually more common in the black population, and the hereditary polyposis syndromes are those syndromes where you find the polyps in a more significant and more common occurrence. So you can classify these polyps in a number of ways. One could be just a macroscopic classification where they're pedunculated, or they're sessile, or they're flat. So these could be the three macroscopic types. Or you can have histological types, like, for example, tubular, villus, villus, or a combination of tubular and villus, which is tubulovillus, or you can have a serrated type of a polyp. That's histological. Or you can classify them based on their propensity for malignancy, like a neoplastic and the other varieties, that is hamatomatous, inflammatory, and hyperplastic. It doesn't mean that the hamatomatous, inflammatory, and hyperplastic are absolutely non-malignant. No, some of them could be malignant given the proper circumstances and the proper variables, right? But neoplastic basically tells you that these are the polyps which would have a high incidence of malignant change. Like, for example, adenomas, 70% of all, we just have said that, and most of them would be having some kind of a malignant potential. Hamatomatous, the juvenile polyp, which is the most common polyp which you find in children or infants who come to you with this rectal polyp. The other juvenile polyps, right? Inflammatory polyps that you usually identify in patients with ulcerative colitis or Crohn's disease, or you can have hyperplastic, which is also an inflammatory polyp. First of all, let's talk about the hamatomatous polyp, just a very short description. And these are, as said earlier, the most common polyp identified in the infant or the child. And it is basically a result of faulty development. That's why the name hamartoma. It's not a true tumor, it's basically hamartoma, where you find a faulty developmental defect, and probably made up of a mixture of tissue, right? What is this mixture of tissue? It could be having epithelial tissue, it could be having connective tissue. So you have both the mucous filled glands and you have a connective tissue, right? And these mucous filled glands along with the retention cysts. And there is a chronic cellular infiltration of eosinophils. So you see the three types of cells pattern that you have. Number one, you have these glands, you have connective tissue, and you also have infiltrating cells. That's why it's a mixture of tissue. And the most common, I said earlier, with juvenile, but it doesn't mean you can't have the others. Creutzfeldt syndrome is also a not uncommon occurrence, and bronchite Canada syndrome, right? The other, the hamatomatous polyp that I said was juvenile. I said earlier, pedunculated, cherry-like, solitary, and is non-malignant, right? But that means the solitary, that's why the word solitary is non-malignant. We just now talked about the hamatomatous, the changes. I'm not covering that. Hematochezia is the most common symptom. If it is multiple, which is a rare type of juvenile polyp, then that is associated with a genetic problem, that is the autosomal dominant inheritance, and that may transform into malignant when multiple and with a family history, especially with juvenile polyposis syndrome. So that basically means that you have a juvenile hamatomatous type of rectal polyp. If it is solitary, no chance of malignancy. But they are multiple, then the chance of malignancy are pretty much there. Why? Because these could be part of a polyposis syndrome, or this could be basically because of autosomal dominant inheritance, right? So there you have to be careful. If you got multiple juvenile polyps, you have to be very careful. The treatment is simple. You go in for a transanal excision or a colonoscopic snaring if you have it in the rectum or the lower part of the colon. But talking about the more proximal part of the colon, that becomes difficult, and we have to go in for other methods. Colonoscopic snaring could work even there, but if it doesn't, then you have to go in for other methods, right? The other benign polyps we just talked about was inflammatory, like the fungal pseudopolyps, seen in ulcerative colitis, multiple benign polyps, right? Mucosal, we have excisions of a mucosa, usually again benign, typical small, less than 5 millimeters. Submucosal, again benign, and the most common submucosal polyp is a submucosal lichen, right? Now, coming to classification basically based on the malignant potential. So, you have got a low malignant potential, a hamatomatous polyp. I just not told you that. And which one I tell you? I told you about the juvenile polyposis syndrome. So, this is basically the types which are there in the hamatomatous, and this is basically telling you about the risk of malignancy. So, here you have an increased risk of colonic and extra colonic malignancy. And you find the polyps throughout the GIT. So, it's not only the rectum, throughout the GI. And autosomal dominant inheritance is there when you're talking about multiple hamatomatous polyps. So these are the syndromes where you basically find these multiple hamatomatous polyps, and they have got an increased risk. So we just have said a solitary juvenile polyp, no. Multiple juvenile polyposis syndrome, yes, there is some incidence of malignant potential, but it is a low malignant potential, right? Coming to a moderate malignant potential. And what are these moderate malignant potential? These are basically serrated polyps, right? So you have got a hyperplastic polyp, which is basically hyperplasia of all the elements, and these have got a sawtooth or serrated pattern of crypt epithelium. That means you got the crypt, and the epithelium which is lying is showing a serrated pattern. That's why it's known as a serrated pattern of crypt epithelium. Minimal risk of malignancy, but yes, it is there. It is there. Small size, less than 5 millimeter, common in distal colon. So here now we are really talking about a polyp which will be there in the rectum, right? Distal colon and rectum. And what do you find in these patients? You find a KRAS mutation and microsatellite instability could be identified in these patients, right? The second is the sessile serrated polyp. Fortunately, it's not very common in the rectum. It's more common in the ascending colon out here. Similar to the hyperplastic polyp that you see on top. Risk of malignancy is around 5%, similar to this. Sessile lesions, more than 5 millimeters. So they're larger polyps as compared to hyperplastic polyps, and common in the proximal colon. But again, coming to one which is there in the rectum, that's a traditional serrated adenoma. It's got a serrated architecture with dysplasia. The risk of malignancy is again 5%. So these are the polyps which have got a moderate malignant potential. But coming to those which have got a high malignant potential, and they are all adenomas. And these adenomas either could be a tubular, a combination of tubular and villus, that's a tubulovillous adenoma, or it could be a pure villus adenoma, right? Now these basically are histologically, you see a finger-like projection line by dysplastic epithelium. Here you find a proliferating cells form a tubule. So this is a tubular kind of histological appearance under the microscope. That's why they're known as tubule. And if you get a combination of these two, it will be tubulovillous. But coming to the tubular adenoma, you start from 5%, less than 5%, and go up to almost 40% or 50%. See the climb in the malignant potential, 5%, 20%, 50%. And that's why villus adenomas are perhaps most dangerous adenoma that you can have, where the risk of malignancy is around 40 to 50%, right? The frequency, fortunately, as compared to tubular adenoma is less. This is 80%. This is only 5 to 15%, right? So tubulovillous and villus 5 to 15%. That is fortunate as compared to the tubulous, which is there 80%. This can be found anywhere, tubulovillous anywhere, and this again villus adenoma could be anywhere, but that means they could be found in the rectum or any other part of the colon. That's why if you identify a polyp in the rectum, remember any kind of polyp in the rectum, a thorough colonoscopy is very, very important. Whichever type. Even if you got a juvenile polyp in a child, it should be mandatory. We usually don't get it done, but it should be mandatory to get a colonoscopic examination of this patient, and either virtual colonoscopy or you can do a real colonoscopy. In a child, probably it would be better to get a virtual colonoscopy, whatever, depends on what the circumstance. But the fact is, a colonoscopy should be ordered in these patients, right? Now, as I said earlier, the villus adenoma is common in the rectum, larger than the other ones, and it's larger than other adenomas and appears like cauliflower. So the appearance on colonoscopic examination, in one you're having a cauliflower-like growth, in the other you have maybe having a pedunculated or a sessile outpouching in the form of a real polyp, right? Villus adenoma, remember, they are usually sessile, as opposed to tubular adenomas, which are pedunculated, or tubulovillous adenomas, which could be pedunculated or sessile. If you look at the malignant polyps that we're talking about, just now talked about the serrated variety. See the serrated polyps, serrated adenoma, serrated architecture with dysplasia. If you talk about that, so usually I said earlier, right colon in the rectum, sessile, already talked about that. Why they known serrated? That's important. And the reason why they known as serrated is they got a sawtooth. You know what a saw is, RE. So they got a sawtooth appearance of architecture of what? Of the crypt lining epithelium. So you got the epithelium, the crypt, the crypt of the mucosa. So that has got a lining which is just like a saw. That's why it's known as a serrated epithelium. The other thing which is important for this is that they could be part of a serrated polyposis syndrome, which is believed to be hereditary, but no genetic defect has been identified up to now, right? They are basically 50 to 30% of all CRCs are attributed to the serrated neoplasia pathway. And what is this pathway? So that means the rest 70% of the pathway is different from these 30% or 15, 30%. And this is basically an epigenetic instability pathway. Now, this is not a genetic pathway. This is an epigenetic instability pathway. Don't worry, we'll talk about that in the next lecture when we talk about the carcinoma of the rectum, right? I'll tell you what the epigenetic instability pathway is all about. So remember, serrated adenomas are important because the malignant potential is only 5%, but they cause CRC by epigenetic instability pathway. Number one, no genetic defect has been identified. Number two, and number three, the name comes from the appearance of the epithelium, and there is a sawtooth or stellate architecture of the crypt lining epithelium. That's why they're known as serrated adenoma. The tubulovillous, we talked about that. I don't think we need to talk about that. I already told you that villous adenoma is a frond-like large appearance. And malignant transformation, yes, we said about 40%, 50%, right? So that is important. Now, these, among all these polyps, what's the presentation? The presentation is the more the polyps and more the frond-like, that's the villous adenoma. They really present, apart from bleeding, that is there. We all know that. But apart from the bleeding, what is important is depending on the number and the size, you could have a whole lot of mucus discharge. You could have electrolyte abnormality in these patients, leading to severe hypokalemia. Because remember, the colonic secretion has got perhaps one of the highest potassium content in the various secretions in the body. Right. So remember what are the potassium contents of the various secretions that are starting right from saliva, the gastric, the biliary, small bowel, large bowel, right, and the rectum. So you have to remember that. So keep learning that and keep remembering it. It will help you throughout your medical career. And biopsy has to be done in all these patients to rule out malignancy. Remember that any polyp in the colon has to be considered as a malignant unless it's otherwise proved, right? The FAP is one of the common, I wouldn't say the commonest, but one of the common syndromes occurring with the polyps, and it's usually autonomous dominant, multiple rectal colonic polyps. Even rarely you can have this FAP syndrome even extending right up to the duodenum. And what do you find in these patients? The genetic defect is the chromosome 5 APC gene there, and most of the 75% affected families who got this gene, 75% they will be having a mutation of this gene, right? Colonoscopic and biopsy is important. Pre-malignant condition, so within 10 years of disease onset, you should do a total colectomy. So if you have been identifying APC in a particular person, within 10 years, this patient should be surgically treated either with a colectomy, depending upon the extent of involvement, and then carry out a pouch anal anastomosis, or go ahead and do a total proctocolectomy with terminal ileostomy, or you can do a total colectomy with ileorectal anastomosis with rectal surveillance. Why is that required? Probably this is one of the better ones, because when we are seeing a multiple polyps in FAP syndrome, what we believe is that the whole part of the colon could be involved, right? So when you're doing, even at that time, suppose you've done a person, so even they have a tendency leave that behind. But remember, that is the mucosa which could be affected later point of time. So the principle is the colonic mucosa. So the treatment should be a total colectomy, right? Now, Treatment rather should be total proctocolectomy. But you have a total proctocolectomy. The problem comes when you do ileoanal anastomosis. You'll have such degree of diarrhea in this patient, and the post-operative management of this patient becomes problematic lifelong. So the better could be that if you could leave a part of the rectum behind, and that's why. But if you leave a part of the rectum behind, which is uninvolved at that time is uninvolved, right? So you can leave a part of the rectum. But remember, even the rectal mucosa could be having a development of polyp at a later point in time. That is why the third option is probably the best option if the rectum is not involved. If the rectum is involved, then the only option remaining is a total proctocolectomy with a pouch anal anastomosis or proctocolectomy with terminal ileostomy, either of the two. But if you find the rectum not to be involved at that point of time, you can go ahead and do a rectal anastomosis. Will give you a pouch. That rectal pouch is important. So this patient will not be having lifelong diarrhea, and you can then go ahead and carry out a rectal surveillance lifelong. Right. So that the third option is the best option if the rectum is not involved at the time of surgery. If the rectum is involved at the time of surgery, then the first two options are probably the option that should be you have to take recourse to. So the syndrome that you find with intestinal polyps, the basal cell lever syndrome, the Turcot syndrome, the Cowden, the Gardner, and Surzeger, just remember them. I'm not going to go into the details of these, but these are syndromes that you should know where you can find the polyps in the colorectal area, right? Now, you have to treat the polyp. So what are the determinants of treatment? This patient comes to you with a polyp. You've done a colonoscopic examination. This patient came to you with hematochezia. You did a colonoscopic examination, right? All polyps should be considered malignant or with malignant potential and should be removed. But at the same time, you have to do a proper analysis of this patient, right? Now, what are the variables to be considered? Whether this polyp could be malignant or not. Because if it is going to be malignant, then you have to carry out some kind of a post-operative therapy in this patient or post-operative surveillance in this patient. So, number one, the types of polyps, we already talked about that, whether it's tubular, tuberculous, or villus adenoma. Number two, the size of the polyp is again important. 1 centimeter size, the risk of cancer is less than 1%. More than 2 centimeters, the risk of cancer is 1%. Point number three, whether it's a multiple or a solitary polyp. Solitary, then chances of syndromes, not only FAP, like example FAP, you can have a number of syndromes that we just not talked about, right? The three important variables out here, right? The primary management starts with a colonoscopy and a biopsy, either excisional if it is a solitary or multiple, then you have to do external biopsy of at least one of them. And that biopsy, at the time when you're doing a biopsy, you should also do what is known as saline lift. And what is saline lift? You inject some amount of saline in the submucosa. If the whole of the polyp lifts up, that basically means it is not infiltrated into the deeper structure. If you find the saline is not lifting up the submucosa, then that basically favors what? A malignancy. So on the colonoscopy itself, you can get an idea whether the polyp that you're looking at is malignant or it is non-malignant. Because if you find the saline lift failing, then that basically tells you a deeper tethering of this particular polyp, chances of having malignancy in that patient, right? And then ultimately, when you've done a biopsy, it has to be sent for HB and you get the frank diagnosis of this patient, right? So treatment of polyps other than syndromic, not only FAP, other syndromic. That means if you got a polyp without any demonstrable syndrome. So what do you do? Less than 2 centimeters, do a transanal approach, or higher up, you do a polypectomy with endoscopic mucosal resection, right? So both can be done colonoscopically. So transanal or endoscopic mucosal resection higher. More than 2 centimeter size, you got to recourse to either transanal endoscopic microsurgery or transanal minimal invasive surgery, either the two, right? That is for more than 2 centimeter size. Or if you find multiple involvement or multiple polyps in a short segment of the bowel, here we are basically talking the rectum, then you have to go in for rectal excision, right? So basically, in more than 2 centimeters, you can have either a TEM or TAMIS, or you can go in for rectal excision. Now, what about the treatment of syndromic polyps, including FAP? There you have to go in for a usual maximal resection procedure, and that maximal resection procedure ultimately lands up with what? A total colectomy. Why? Because most of the time you find more of the colon involved in these patients, right? Now, complications of polypectomy is important, and that is incomplete removal, number one. Number two, bleeding. And number three, perforation. Perforation is a real complication even before you do a polypectomy. when you're putting in a colonoscopy complication itself is a perforation. Right. So it's so important that you do excision, you go deep enough, and you cut you go through the muscular propria, and you lead to a perforation. So perforation either induced by colonoscopy or perforation induced after polypectomy. So these are important, and incomplete removal is again important. Why? Because that will put a different perspective in the post-operative management of these patients. So what do you do in a subsequent management of a colorectal polyp? The guidelines are pretty clear. If you're not doing any kind of surgery, you said, I would like to wait. So when can you wait? A surveillance colonoscopy basically means that you keep surveying this patient. When? Number one, in a low risk adenoma, that means 1 or 2 adenomas with less than 10 millimeter in size. You can afford to leave it behind that particular point of time, and it is probably unnecessary to do a surveillance. That means you do a colonoscopy once and then you can forget about it. Right? Or you do in these patients, you do a polypectomy and then forget about this patient, don't require to do anything. If the patient had more than 3 or more adenomas or adenomas larger than 10 millimeter or high risk of high features on HP. Now, this patient after polypectomy, you can go in for a surveillance colonoscopy at 3 years after baseline. That means I did it today, 3 years subsequently. Baseline basically means the first day that you did a colonoscopy and then subsequently 3. So you have more than 3 or more, number one. Number two, size 10 or more. And number 3, high risk on HPE. 3 important features which would dictate that the surveillance colonoscopy should be done at 3 years. Now, subsequent management after polypectomy. So you've done a polypectomy. Now you've done a complete removal of colonoscopy. You're happy. You don't do anything. HP tells you it's a low risk. Forget about it. Sometimes you may require follow-up surgical excision. Why? Because this patient tells you, or the HP tells you that look, the margins that you sent to me, they had those cells infiltrating. That means incomplete removal. If you had incomplete removal, you may like to go in for a complete surgical resection. So follow up with a complete surgical resection, or follow up with a surveillance colonoscopy. And what should you do? Why this surveillance colonoscopy, and what dictates when you should do it? So a repeat colonoscopy may be advised at 3 to 12 months if the adequacy of the polyp removal is a matter of substantial doubt. That means the histopathology comes that margins are probably involved, they're not clear. So 2 options. Number one, you can go in and repeat that excision, or you can say that let me wait. So you do a 3 to 12 monthly repeat colonoscopy. And if you find no colonic polyps at the initial examination, then follow-up colonoscopy at approximately 10 years interval is recommended. So today I did a polypectomy, the next one I did 3 to 12 months, I didn't find any growth. After that, I can do it 10 years interval, right? So I don't need to do it every 3 to 12 months. I can do it after 10 years. In those patients who have done a complete removal of a low-risk adenomatous polyp, as defined histologically, like for example, a juvenile polyp, solid juvenile polyp, if I removed it, then I can probably do a 5 years, or I can forget about it. So remember, in those patients we have a low-risk adenomatous polyp, because that patient has juvenile polyp. If you find the biopsy as adenomatous polyp, so the 2 things are different. One, where there's a low-risk adenoma, in that case, you can afford to leave. You don't need to do a colonoscopy again. But in those patients where at that time the histopathology said absolutely clear, but it was an adenoma, then that patient you have to go in for a 5 years repeat colonoscopy. So remember, this colonoscopy you can do anytime, but there are certain guidelines which will tell you when you should do a colonoscopy, when you should not do a colonoscopy. Is that clear? I think we'll finish it today because rectal carcinoma is a large part of rectum, and I think we'll talk about rectal carcinoma day after tomorrow. That means today is what, 10th, 11th. On 12th, I'll be taking rectal carcinoma. That will take the whole lecture. And if you got any questions up to these benign problems of rectum, I'm ready to help you out. Any questions? No? Okay, thank you. I think we'll talk about the rest rectal carcinoma next time.